Thank you very much for the opportunity. I am Dr. Saman Renuka, consultant orthopedic surgeon from Sri Lanka. We'll discuss on acute DRUJ injury that can be isolated or associated with distal radius fractures. Just we'll have a look at the stability of the DRUJ. We can see that the stability is provided by the bony congruity, soft tissue stabilizers that can be static or dynamic. The major soft tissue stabilizer is the TFCC. So it is a complex structure. The main stability is provided by the dorsal and volar distal radioulnar ligaments. You can see they are attached to the ulnar margin of the sigmoid notch and to the distal ulnar. Ulnar collateral ligaments, meniscal homologue, articular disc, and ulnar lunate and ulnar triquetral ligaments. Those two ligaments are histologically different from the other structures, and especially extensor carpi ulnaris subsheath. When we look at the anatomy, we can see that the radius of the sigmoid notch is around 18 millimeters, and the radius of the distal ulna is around 8 millimeters at the articulation. So there is incongruity of the joint. So that provides rotation movement and gliding movements at the same time. And both DRUJ and ulnocarpal joints are anatomically and functionally interrelated. We just have a look at the dorsal and volar distal radioulnar ligaments. Those are the main static soft tissue stabilizers. The deep ligaments are attached to the fovea of the distal ulna, and the superficial component is attached to the ulnar styloid process. So those two components have different actions. So we can see that the deep component is attached at the fovea, that is the fulcrum. So their length remains same during supination and pronation. But the superficial component, which are stretchable, and that the length changes with supination and pronation. So we can see that during supination there is stretching of the dorsal superficial component of the distal radioulnar ligament and the deep component of the volar distal radioulnar component, and the vice versa during the pronation. When we consider the morphology in the coronal plane, we can see that the DRUJ can be parallel articular surfaces or oblique or reverse oblique. There is no much difference in stability depending on the obliquity. But when we are doing the ulnar shortening osteotomy, there may be much more loading on the ulnar head when there is a reverse oblique morphology. When we look at in the axial plane, the sigmoid fossa articular surface may be flat, ski slope, C-shape or S-shape. If the articular surface is flat after repair of the ligamentous structures after the DRUJ injury, there may be a high chance of instability. So the patient may need some kind of osteoplasty. And we have to specially consider the distal oblique bundle of the interosseous membrane. That plays a vital role. Even the whole TFCC is cut off from the ulna, that may give stability. That is why we have to achieve the anatomical reduction during rigid fixation of the distal radius fractures to prevent laxity of the distal oblique bundle. Even though there are several classifications for TFCC complex injury, it is easy to use the Palmer classification. The type 1 is traumatic injuries and type 2 is degenerative injuries. Type 1 can be subcategorized into central perforations of the articular disc, foveal insertional tear from the styloid process, and 1C is tear of the ulnocarpal ligament. Those are the ulnar lunate and ulnar triquetral ligaments, and 1D is radial side insertional tear. That is uncommon. We have to suspect instability when there are osseous deformity, like in extra-articular distal radius fractures. There is radial tilt, which may be volar or dorsal, or radial shortening, or if there is a fracture in the sigmoid notch area. When we look for the instability, so one of the best examination technique is the DRUJ ballotment test. But those provocative tests are very painful because of in the acute setup, we may consider these examinations under anesthesia. We have to do this test especially after rigid fixation of the distal radius fractures. So now we look at the few investigations. The easiest way is doing the plain X-ray, that is PA and lateral and sometimes oblique views, and CT scan. In our setup, MRI scan is not that practical. When we consider plain X-rays, we have to suspect DRUJ instability. When there is a radial shortening, which is more than 3 millimeters, or dorsal and volatile, those are more than 10 degrees, or radial shortening that is more than 3 millimeters. So if those findings are there, there is a high chance of distal radio-ulnar joint instability. The other important investigation is the CT scan, especially in distal radius fracture is associated with this instability. We can look at the sigmoid fossa in axial cut and the bony configuration, that's the fracture configuration in acute distal radius fracture. So now we'll talk about the management. It's a well-known fact that most of the ligamentous injuries, that is around 40 to 50%, will heal if we manage properly by conservative methods like splinting. Depending on the ligamentous part injured, we have to consider to prevent supination and pronation by applying elbow joint POP backslap or applying a sugar tongue splint. Operative techniques can be acute repair that can be open or arthroscopic. In our setup, we usually go for the open repair. We can consider reconstruction and salvage if acute repair fails or if the injury is delayed. So now we'll talk about open repair, and there are few examples we had experience in our setup and we went for open repair. This is the X-ray of a 47-year-old lady doctor, and she has sustained left wrist twisting injury, and she has noticed locking sensation of the wrist with severe pain. She has presented to the nearby tertiary center, and there the relocation has been done without anesthesia, and she has been with below elbow joint POP backslap. She continued to have pain, and this is the 2 weeks X-ray where we can see the dislocation of the ulnar head volally. So she presented to me at 3 weeks, and this is the MRI finding. we can see volar subluxation of the ulnar head and obvious tear of the dorsal distal radio ulnar ligament, and you can see the extended digiti minimi tendon in the space between the distal radius and the ulnar. So she has got complete tear of the dorsal distal radio ulnar ligament, and we can see some remnants of the volar component. So we are operated under general anesthesia with tourniquet at the arm. We went through the fifth extensor compartment. So then we were able to retract the extensor digiti minimi radial word. Deep distal radio ulnar ligament was still attached at the fovea. So I was able to reattach the fiber cartilage and dorsal component of the deep ligament with 2-knot ethibond to the remaining attachment at the distal ulna. So the repair was fairly satisfactory, but for the further protection we inserted 3 cortices transfixing K-wire from ulnar to radius. Then the capsule and the extensor retinaculum was repaired and patient was put on a POP back slab which was above elbow, and we did the transfixation of the distal radius and ulnar with the forearm in neutral position. At 4 weeks we removed the K-wire and she was with the wrist splint to get the protection for the wrist movements. And at 6 weeks we referred this lady to the hand therapist at another tertiary center, and she continued the mobilization protocol. And this is the recent most video clip. Now we have done the surgery almost 1.5 years back, and the wrist movements are pain free, and she has got the almost complete range of the wrist movements, and she is very much happy with the outcome. The second patient, there's a DRUJ instability associated with distal radius fracture. This 47-year-old teacher had a fall, and he has slipped and fallen and came to the emergency department with this deformity of the wrist, and there was sensory impairment over the median nerve innervation. We did the surgery on the acute setup, that's that day night itself. So under anesthesia, this is the traction view. So this is after the fixation. We use DVR plate to stabilize the distal radius fracture and locking plate for the ulnar shaft fracture. Then with the ballotment, there was a gross instability. So again we went through the fifth compartment, and stylet process was attached and stabilized with 2 K-wires. We didn't go for any kind of figure of 8 circle arch wiring because there was adequate stability, and the K-wires were sent which were a little bit oblique to each other, so the displacement, I think it is very unlikely to happen. Just for this protection, we applied the splint to prevent wrist movements. At 4 weeks, we started gradual mobilization of the wrist movements, and At 3 months, patient was happy with the outcome. Still, we didn't remove the ulnar KYS, and I think patient is happy with the outcome. So we discussed both pure ligamentous injury and a DRUJ instability associated with distal radius fracture. And both cases were operated at the single theater setting. And because we have a difficulty of finding suture anchors in our setup, we did the direct repair, and if the ulnar side was broken, we fixed with KYS. Thank you.